Hello and welcome again to another edition of the Osteopathic Lyceum podcast. Going to go through an article because, again, in good faith, I'm attempting to gain a better understanding of best practice guidelines or best practice care, however, whatever term ends up showing up, especially with respect to patient outcomes. Because once again, I have been previously informed that best practice guidelines are generally the location that I will find evidence that evidence-based medicine as an approach has improved patient outcomes. Okay, now I can't tell you that I've read everything because I damn well have not. I really haven't. But I'm attempting to show the process of reading more and more so that I can display what that behavior looks like. So instead of flippantly dismissing something, taking it to heart, attempting to look at it, attempting to see whether I should increase my confidence or decrease my confidence in that claim, so that within the realm of hands-on manual therapy, I can increase or decrease my confidence that importing a concept from somewhere else will have the impact that one would hope. Now, it doesn't mean it will not. It doesn't mean that it will. It doesn't mean that it could not. It doesn't mean that it could. What it means is I'm just trying to adjust my confidence in that idea, right? Or see if my confidence should be adjusted is maybe the better way to put it. So the paper that I'm going to look at, and the search was just simply best practice guidelines this time. So last time it was best practice guidelines and patient outcomes. This time it's best practice guidelines through Google Scholar. Not necessarily a perfect search, but it will show something. I scan through, I find something, and then here we go. So the article here, what does best practice care for musculoskeletal pain look like? 11 consistent recommendations from high-quality clinical practice guidelines, systematic review. So essentially from the title, what you can gather is that they used a systematic review approach, which is a rigid, accepted step-by-step approach. You do it in a particular way. You set your inclusion-exclusion criteria, and then you go ahead and you look and you judge things as to whether or not you should include them or exclude them. The consistent challenge with that is that it doesn't end up telling you what the literature says broadly. It tells you what it says narrowly about what you told people you were willing to check. So it has value because it accurately represents what the researchers chose to do, but it doesn't necessarily accurately represent what the literature states. It does represent what the literature states about what the authors chose to look at, but it's not broad. It's very narrow. That is not necessarily a problem. It is defensible, but don't mistake it for telling you what the best stuff available is. Think about it as what the best stuff available that the authors chose to do or digest and knowledge translate is. That's what it is. It's what they chose to do knowledge translation on. Okay. I already told you the title. What's wrong with me? So I'm going to get into the paper. I'm going to read very superficially or very quickly because some articles and some publishers are doing a pretty good job of creating these little mini bites. There's this box. Hopefully, if I get my face out of the way, this will happen. Will it happen? Will it happen? Probably not. Light's probably wrong. It's kind of like what is already known. So here to read what is already known really quickly as bite-sized things. There's an urgent need to improve quality of care for musculoskeletal pain conditions, MSK. This is a priority for clinicians, healthcare services, researchers, and policymakers. MSK pain in different body areas share similar features, and it may be possible to identify consistent overarching recommendations for assessment and management. Identifying common recommendations could be a useful way to improve care quality. The moment you see healthcare services, researchers, and policymakers, not the clinicians, the healthcare services, depending on the country, they could be talking about like hospital systems or government intermediated payment systems. Not always, but that's a possible interpretation of that as a broad term. I think this is from Australia. Is it from Australia? Yeah, it's from Australia. So that might be how they're using it. When you see researchers, there's You need to make a case to get funding for research as it stands right now. And then when you see policymakers are going to be concerned about the balance of spend and get, right? So what they spend for what they get is what they're looking at. So you're not necessarily looking for, it doesn't necessarily say patient outcomes there, right? The end goal of any form of care system should be the patient outcome. It's probably better if it's cost effective, but sometimes it's going to get costly. To read another bullet, MSK pain and different. Yeah, I already read that. Whatever. Improve care quality. Yeah. To read another set of bullet points, what are the new findings? We identified 11 consistent recommendations for MSK pain from high-quality clinical practice guidelines. So they did a systematic review on previously existing guidelines to see what's the same. One of the challenges with clinical practice guidelines is that they are not the same. They are not made by the same groups. They are not distributed widely. They tend to be distributed narrowly. One of the reasons for that is the administrative circumstances of varying locations of care provision. To read again, these could be used to improve MSK pain care by assessing care quality, for example, through audit, guide clinical decision-making, and identify clinician education needs. I understand why you would want to do that on a population level. Unfortunately, if you make a choice on the population level for education, usually what you're going to be required to do is get a base level, not necessarily a level to improve an individual, right? If you see a base level need, you tend to target there. Expertise develops on top of that. So, I understand the concept and the aim, but especially when you attempt to apply it broadly, you might miss a bunch of stuff. A lot of people are probably at that base level anyways. Continuing education is actually a really, really hard nut to crack. It's very, very hard to figure out how you can improve provision of care broadly with something like continuing education, because the people actually have to be willing to engage in it. They actually have to be willing to do it, or change their behavior based on it instead of just check the box with which their professional oversight, whether it's a regulatory college or professional association, tells them you have to check this box. So they check the box and they don't really check in. So I'm going to continue to read here. So the background, this is in the actual paper. Musculoskeletal pain, MSK pain conditions are the biggest cause of disability internationally. Fair enough. And a major societal burden. One contributor to this burden, which is becoming increasingly recognized, is poor quality healthcare. Common healthcare problems for MSK pain are summarized in box 1 and include overuse of radiological imaging, surgery, and opioids, and a failure to provide patients with education and advice. One of what I would suggest as a prediction, the reasons that pain care, MSK pain care, is so challenging is because pain is not accurately identifiable by other people. And there are assumptions that that permeate most healthcare professions, where if you find anatomical abnormality and you change it, that will change pain. And it does sometimes, it does not always. So surgical intervention, the point of a surgical intervention is not to change what you feel. It's to change the structure, whether to sew it back up, to shave it down, to change its shape, stuff like that. It is not targeting pain mechanisms. It is targeting the anatomical structure to change it to what would be considered some greater ideal for function, not for pain. Usually, after the recovery, the pain generator from the anatomical abnormality may have changed and people have a positive outcome, but it is not consistent. It is highly variable. So MSK pain, because it is not something that is identifiable by anybody other than the patient, there's a lot of assumptions that it is the anatomical abnormality driving it. So yeah, MSK pain care is hard because it's a target that only the patient can identify. So your results are going to be variable. And I think you're always going to have a hard time actually targeting it and improving it at the population level. because it is multifactorial and it is variable between individuals and even within the individual. So it's just a hard thing to target. So you're going to have problems when you look at large data. The overuse of imaging here. So I'm going to read this really quickly. This is box one. Summary of common problems in MSK pain care. Overuse of imaging. Between 25 and 42% of patients with low back pain undergo imaging. That's a pretty darn big range, but it would depend on how it was collected and where it was collected. To read again, even though its routine use is discouraged and associated with harms. The harm could be radiological, so the dose of radiation, but also it could be the psychological and emotional impact of the person understanding a particular new piece of information, putting all of the weight on that new piece of information, and that not being the thing that's driving the discomfort or the pain. So that could be where the harm comes from. To read again, 69% of general practitioners would refer patients for radiography at first presentation of rotator cuff tendinopathy, and 82% would refer for ultrasound. Right? Yeah, despite findings demonstrating a poor relationship between imaging findings with symptoms. So that's what I already talked about. Just because there is an identifiable anatomical abnormality doesn't mean that that's the driver of the symptom. Symptoms are what only the patient can identify. Signs are what everybody, including the patient, can identify. So when you're targeting symptoms, this is going to be constant. This is just the nature of symptoms. They are reported to healthcare professionals, and healthcare professionals cannot observe them, but they can observe their proxies, so they can try to work on it, but it is, it's like a conundrum wrapped in a mystery. You can get close, but you're not going to get there consistently. There's difference in language use, even within people from the same culture or the same area. It's hard. This is just a hard thing. To read again, overuse of surgery. Knee arthroscopy for knee osteoarthritis is not recommended, yet its rate of use in the general U.S. population increased from 3% to 4% from 2006 to 2010. The rates of shoulder subacromial decompression and rotator cuff repair have increased markedly, even though surgical outcomes are comparable with exercise rehabilitation or sham surgery. Right? So again, the anatomical abnormality may not be the driver of pain. This is a consistent and complex phenomenon, unfortunately. Reading again, overuse of opioids. The efficacy of opioids for MSK pain management is questionable for both chronic and acute MSK pain conditions. Opioids having a much higher addiction profile than things like NSAIDs or non-steroidal anti-inflammatory drugs. So there's challenges with opioids, period. The early use of opioids has been associated with poorer outcomes in low back pain care. Although limiting the use of opioids is recommended, there is increasing use and an epidemic of prescription opioid-related harms. The rationale for increased opioid use may not necessarily have anything to do with the presentations that people show up with. It may have to do with other processes that are not necessarily directly the simple choice of the care provider. There may be some other factors influencing that, and that's all I really want to say on it. To read again, failure to provide education and advice. These are cornerstones of managing MSK pain conditions, yet only 20% of patients with low back pain were given advice and education in a primary care setting. Right? Well, primary care settings, if you don't know this, are very overburdened. The practitioners only have a certain amount of time, depending on the payment model. If you have an insurance-mediated payment model as a primary care provider, especially as an MD, you have no time to spend with patients. Not because you shouldn't, but because you don't. You've basically got to pump people through. You're not going to get fully reimbursed for the vast majority of your services. You're going to get partial reimbursement. You got to fight. You got to waste time. You got to write a lot of notes. So, yeah, the payment model often is part of the rationale for not getting certain things, because the practitioner can't do it because they have to fight for money. Right? To continue to read, evidence to practice gaps such as these are problematic because they waste healthcare resources and prevent patients from receiving appropriate care. One of the foundations of efforts to improve healthcare and to reduce evidence to practice gaps are clinical practice guidelines, CPGs. CPGs are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and assessment of the benefits and harms of alternative care options. So CPGs are primarily generated from systematic review. It doesn't mean it's the only thing, but primarily that's where they come from. CPGs aim to improve care in a number of ways, including guiding clinical and patient decision-making, acting as a standard of care, contributing to the development of clinical decision-making aids, informing all stakeholders about what constitutes best practice, and guiding allocation of healthcare resources. So one of the things you could say is that if the patients know what the clinical practice guidelines are, they can catch the doctor if they're not necessarily doing them. That's something that's reasonable, because then it would fall under the concept of standardized approaches, such that if everybody knows the approach, then if somebody's making an error, another person can identify it. It does possibly create a mildly adversarial relationship, but it's a different discussion. To continue to read, care that is more concordant with CPG recommendations results in better patient outcomes and lower costs. So this, I already looked at this, and I'm going to do this quickly in front of you. So this is references 5 and 6. So reference 5, the title is Implications of Early and Guideline Adherent Physical Therapy for Low Back Pain on Utilization and Cost. So how much do people use it, and how much does it cost? That's not something that I'm going to be exceptionally interested in, because I'm more concerned about the patient outcome. The patient outcome is the patient is the target of all my skills and all my efforts, and any healthcare practitioners. Not any healthcare administrator, that's different, but the healthcare practitioner is looking to use their skills to benefit the patient. The second one, number 6, is adherence to clinical practice guidelines for low back pain and physical therapy. Do patients benefit? Okay, so I'm going to click on this. I'm going to go over to another paper to read the title again. Adherence to clinical practice guidelines for low back pain and physical therapy. Do patients benefit? Okay, so I'm going to read from the abstract here. Various guidelines for the management of low back pain have been developed to enhance the effectiveness and efficiency of care. Evidence that guideline adherent care results in better health outcomes, however, is not conclusive. So again, this is just me pointing to, it has been suggested to me that I will find evidence about improved patient outcomes when I look at best practice guidelines. Okay, so I'm going to look at a paper that's talking about patient outcomes and best practice guidelines. I don't have the full paper. I have the abstract, so there may be information in here that I am not aware of, but I have the abstract. The objective, to read again, the main objective of the study was to assess whether a higher percentage of adherence to the Dutch physical and manual therapy guidelines for low back pain is related to improved outcomes. The study further explored whether this relationship differs for the individual steps of the process of care for distinct subgroups of patients. Design. This was an observational prospective cohort study, 2005 to 2006, in the Netherlands that included 61 private clinic practice therapists and 145 patients. Methods. Therapists recorded the process of care and the number of treatment sessions in web-based patient files. Guideline adherence was assessed using quality indicators. Physical functioning was measured by the Dutch version of the Quebec Back Pain and Disability Scale, and average pain was measured with a visual analog scale. Relationships between the percentage of guideline adherence and outcomes of care were evaluated with regression analyses. So, okay, Quebec Back Pain and Disability Scale, or the Dutch version, that would be considered a validated tool. So I don't know the exact details of that one, but you would have some trust that it could be deployed similarly, and the results would be within a range that you'd understand and accept, and that's fine. The average pain was being measured with a visual analog scale. Self-reporting is tough. It has flaws. It is not useless, but it has flaws. So that one, my confidence wouldn't be great in, but the Quebec Back Pain and Disability Scale I'd be more interested in the disability portion of it, because that would be a measurement that other people would agree on, whereas any pain measurement, very hard for people to agree on. And user variance would influence what I would be able to interpret from that. So there's something here, right? You could track down and repeat the methods. You could probably do a pretty good job, and maybe you'd come up with similar things. I couldn't tell you. But the fact that they have, like web-based patient files, people will write things down that aren't exact representations of how things went, and especially if they know what it's supposed to look like, a lot of people will write notes how they're supposed to be written as opposed to as accurate representations of reality. So you have some challenge there. It doesn't mean it's useless. It means you have some challenge, so there's challenge there. Anyways, to read again, results: higher percentages of adherence were associated with fewer functional limitations. and fewer treatment sessions. The p-value of 0.023, yeah, that's fine. So there's some statistical significance with a p-value or the confidence interval. Fewer treatment sessions. P is 0.005, so that's decent. Limitations. Okay, so the limitations here: relatively small, self-selected sample might limit external validity, but it is not expected that the small sample greatly influenced the internal validity of the study. So the internal validity was we did things the same way. The external validity is this will translate to other places more or less. Larger samples are required to enable adequate subgroup analyses. Conclusions: the results indicate that higher percentages of guideline adherence are related to better improvement of physical functioning and to lower utilization of care. A proper assessment of the relationship between the process of physical therapy care and outcomes may require a comprehensive set of process indicators to measure guideline adherence. So they got some signal, but this isn't strong. This isn't them saying we're definitely sure that it was the guidelines that made the difference. They're saying that we've got some signal, so it would be worth chasing this down more, but we would need a more robust experimental process. So I'm happy that there's some signal that increases my confidence that maybe practice guidelines hold some of that. But the rest of, sorry for hitting that, the rest of what we're going to go through hasn't necessarily improved my confidence in that. So I'll go back to what the heck we were reading. Jeez. No, what? Oh, come on. Some of these websites stink. I clicked back and it went back to only the abstract when I was already on the full text. And that didn't make me particularly giddy. Yeah, here we go. To read again. However, CPGs have been criticized because clinicians have difficulty using them. Issues include a multitude of CPGs for the one condition or when they are voluminous documents that are not user-friendly, shortcomings in their quality such as when developers have undisclosed interests, and a lack of transparency in their development. So the previous video that I did, or the previous podcast that I did about clinical practice guidelines, shares these same issues that stakeholders sometimes will create clinical practice guidelines that should drive behavior in the favor of those developing the guidelines, often monetarily, or possibly monetarily is maybe the more appropriate way to say that. So I make a clinical practice guideline, and in that clinical practice guideline, I'm asking you to utilize my personal product. Sorry, phone calls coming through from somebody. I'm not going... Yeah, whatever. Phone calls coming through. I'm just getting distracted. Thank you. Sorry, rather. So if I create that guideline and you have to buy my service, then I'm benefiting. So the guideline might have an issue there. These problems are reflected in contemporary MSK pain CPGs. We recently reported that most MSK pain CPGs are of poor quality, use inconsistent terminology, overrepresent some conditions, e.g. low back pain and osteoarthritis, and underrepresentation of other conditions, e.g. cervical and thoracic spine pain, and fail to outline how to implement CPGs. So one of the things that was suggested to me is that the CPGs really are one of the backbones of evidence-based medicine because they tell you how to apply knowledge clinically. This is suggesting that maybe they don't do that as well as one would hope. To read again, nevertheless, we also identify a small number of higher quality CPGs that could be used to inform healthcare of MSK pain conditions. I'm not going to read the methods. I'm going to, because it's systematic review, right? They also do note they published their methods in Prospero. The methods, they do note where they deviated. I don't think it's a giant deal here. I'm going to... So there's a narrative summary, but what I'm going to do is I'm just going to read how do I want to do that? No, I'm not going to do that. I'm going to read you the actual clinical practice guidelines. So a clinical practice guideline, one would hope that it would improve their ability, the practitioner's ability to do something accurate, improve care. So it should be a very actionable item. It should be very clear. Or one would hope that it would be very clear, very actionable. It would be something maybe novel that they wouldn't have thought of before. But so I'm going to read what this systematic review was able to extract as high quality guidelines. Care should be patient-centered. This includes care that responds to the individual context of the patient, employs effective communication, and uses shared decision-making processes. That's just good clinical behavior. That's not new, right? Healthcare ethics require that you are patient-centered in the manner in which it requires that of you is non-maleficence. First, you must make a choice that you believe will not harm the patient. Beneficence after that. You must make a choice that should benefit the patient. Autonomy. You should provide the patient the opportunity, the ability, or not should, you are required to provide the patient the opportunity and the ability to accept or reject treatment based on information that they can understand. Like, this is already in healthcare ethics. Sure, maybe somebody needed to know this, but if you're a doctor already, I really hope you didn't need to know this. Maybe if you're some other form of healthcare practitioner, we could argue about it, but like, this is a big fat no duh, whatever. Next one, practitioners should screen patients to identify those with a high likelihood of serious pathology, red flag conditions. Like, this is ridiculous. This is not something that a clinician needs. You should screen patients to identify those with a high likelihood of serious pathology, red flag condition. Like, are you really? Of course you should. That's just regular diagnostic procedure. Like, this is insane. Psychosocial factors should be assessed. Like, you should figure out if the reason they're having pain is because there is a mechanical pathology or something psychological or emotional, possibly caused by an annoying person in their life. Like, again, this is no duh. This is normal diagnostic process. I think one of the reasons that you would argue that some people do need to be reminded of this is because busy practitioners may be perceived as dismissive, because one of the things is, if you're busy, you're going to pay attention to the people who need your care as opposed to the people who want your care. That would be the argument of the practitioner. So it's tough. Next one, radiological imaging is discouraged unless one serious pathology is suspected, aka what you should already be doing. If you don't suspect serious pathology, you should downplay radiology. This is not new or really all that useful. 2, there has been an unsatisfactory response to conservative care or unexplained progression of signs and symptoms. So you had a belief, you made a diagnostic call that it should be whatever you think this is, should respond to a particular form of care, and then it doesn't. You need more information, therefore you step towards imaging, aka a higher resolution opportunity to observe area of problem. It's called DDX, differential diagnosis through treatment. Like, okay. 3, imaging is likely to change management. So if you think imaging is likely to change management, then go ahead. If you suspect some major pathology, imaging is likely to change management. If it's there, then you know which direction to go. If it's not there, you know that you shouldn't do that thing. Like, sorry. Next one, assessment should include physical examination. Physical examination could include neurological screening, tests, mobility, and or muscle strength. Somebody has MSK pain, you should do some physical exam. Like, come on, man. Like, you must, whoever has been writing CPGs must think their physician colleagues are morons that haven't already been trained to do this or wouldn't do this. I don't know where you get the... like, I will say that there are going to be physicians patients present to who have MSK complaints and don't get a physical. I'm aware that happens, but like, yeah. Okay. Next one, patient progress should be evaluated, including use of validated outcome measures. So you should assess them, you should treat them, and you should reassess them. Yeah. Basic behavior. Next one, all patients should be provided with education information about their condition and management options. You're already required to do that for patient autonomy. Like, now, yeah, sure, physicians could be falling down on this, and other healthcare practitioners could be falling down on this. Fair enough. But I mean, this doesn't seem like some, world-shattering, practice-changing thing. Just do the thing you're already supposed to do, dum-dum. Next one, patients should receive management that addresses physical activity and or exercise. If you have MSK pain, generally, very broadly, physical activity helps manage it. It could be because it improves physical resilience, it improves physical qualities of a variety of forms, or it could introduce a new, stronger sensation that you pay more attention to than whatever the MSK pain happens to be. Next one. If used, manual therapy should be applied only in conjunction with other treatments. So, hey, all you hands-on therapists, you shouldn't be doing anything unless the doctor said that you should do something for this condition. Okay, if you say so. Because patients are definitely going to go to their doctor first when their shoulder hurts and they feel like the doctor is going to be dismissive to them because they've had bad experiences in the past, and that's a constructivist lens, right? So, okay. Unless specifically contraindicated, e.g. red flag conditions, offer evidence-informed non-surgical care prior to surgery. If I'm not mistaken, for the most part, orthopedic surgeons are generally actually doing this. Very broadly, surgery is being downplayed for a lot of MSK conditions because the thing that has been noted across time is that the outcomes at certain time points are really not a ton different if you have the surgery, if you don't have the surgery. One of the reasons that orthopedic surgery is going to be more utilized is if somebody has to go back and do something physical sooner, whether that's athletic performance or job performance. If you have to do it within a shorter time frame, the surgery seems to be able to get you there quicker, but not necessarily get you to a better place, is my current understanding. To read the next one, facilitate continuation or resumption of work. Yeah, I mean, if somebody can't work because they're in pain, then you gotta challenge because they can't feed themselves and pay their bills. Yeah, that's all of the recommendations. I just don't. Maybe my perspective is one that is possibly relatively well informed, which is why I find a lot of this laughable as the strongest clinical practice guideline recommendations for MSK pain. Either that or the people writing CPGs for MSK pain really think other practitioners are absolute dum-dums, right? Maybe they do, maybe they don't. Maybe I need to see more, but if that's sort of what clinical practice guidelines tend to look like, and I don't know that they do. I looked at a few others and I didn't find them exceptionally informative. It doesn't mean that they are not. It means that I did not find them that way. I mean, they just seem to be possibly make work for people who like to write stuff up and tell other people what to do. They could help care on some levels, but this feels like a pamphlet, 10 questions you should ask before this. Okay. If you have made it to the level of providing any form of clinical service to anybody and you don't know that you should screen for red flags and contraindications, and that if things aren't making sense that you should refer to a higher level of diagnostic, then maybe you could improve your skills as a personal thing. But if your skills are low, you don't know. So that's a challenge too. There's a lot of funny business going on with these CPGs as far as I can tell. They unfortunately make me laugh on camera to some degree and make me wonder if the people that are writing these just really like to tell other people what to do and think that their colleagues are dumb. Kind of seems that way so far with what I've seen. But anyways, although what I'm saying has criticism in it, I am attempting to show good collegial behavior. Again, and I've said this obviously before, you listen this far, you've heard me say it, that the point is to attempt to test my confidence in whether or not CPGs, clinical or best practice guidelines or clinical practice guidelines, offer the evidence that adhering to clinical practice guidelines improve patient outcomes. So far, I have found very little of that, very little evidence that suggests that that's actually tested or checked, or that it is clear that the application of the clinical practice guidelines are the key factor to difference in outcomes, if it exists at all. I've basically seen very little that it exists at all, and what I have seen is not inspiring deep confidence in me. That doesn't mean it doesn't exist. It just means my confidence isn't increasing and I'm not finding it in the manner that I'm searching so far. And when I actually read the clinical practice guidelines, again, my current read is that the people that write them think their colleagues are dumb. So thank you for listening this far. Hopefully you've learned something, and we'll speak again soon.